let people jump in, and then we'll start off with our speakers. So first and foremost, thank you so much, everybody, for coming. I know it's a weekend and everyone's time is very precious. So good morning, good afternoon, good evening to everyone, wherever you're joining from us today. My name's Adel. I'm a neurosurgery resident at Duke in North Carolina in the United States, hoping to subspecialize in skull-based neurosurgery. And it's a real pleasure today to be joined by two amazing co-hosts, Dr. Muhammad Abdel-Bar, who's a professor at Duke and an expert in minimally invasive spine surgery. He's also the co-chair of the WFNS Innovation and Technology Committee. And of course, renowned skull-based expert, Dr. Daniel Prevedello of Ohio State University, and also co-chair of the WFNS Skull-Based Surgery Committee. So just as a brief background, as you all know, over recent years, global neurosurgery research has seen a huge explosion. And fortunately, with that has also come some neurosurgery capacity. Especially as in the background of that landmark 2015 study from The Lancet, which showed that in low and middle income countries, we need 143 million more surgeries every year, with neurosurgery comprising a major need. So rightfully, much of the initial work has been devoted to building out the trauma care in neurosurgical sense. And as that has continued to develop, it's, I think, incumbent upon us to grow other areas of neurosurgery as well. And tumor surgery, especially skull-based surgery, is another critical unmet need. Traditionally, it's a more resource and training intensive subspecialty within neurosurgery, which may lead to it being a bit slower to develop. And even with less resources, physicians and LMICs are asked to do even more, for example, with tumors presenting larger and later in the clinical course. So in those settings, how do you weigh the trade-offs between the extent of resection and possible complication avoidance in a context where redo surgeries really strain the patient and medical systems? So there have fortunately been a few recent papers highlighting the experience in some countries regarding skull-based surgery, but really we don't have a good sense from a global perspective where we're at. So today I hope that we can hear the stories of the growth of some skull-based programs, including challenges and successes in 3 different countries. And we hope that hearing these stories will shed some light on what is possible even when resources are more limited, and then start a conversation about how to continue expanding our ability to care for these patients who need our neurosurgical expertise. So before I introduce our first speaker, I'll hand it off to Dr. Abdel-Bar to see if he has any other introductory comments, and then Dr. Prevedello as well.
Great. Thank you so much, Adel. And first of all, I'd like to thank Adel for his really humongous effort. He came to me with an idea and he, basically took over. And this is so great to see this culmination of his effort. I think it's great for us to really see, what, as he said, the unmet needs, and also to see how other countries that may not have as much resources have dealt with these issues. And as the chair of the innovation technology, it's been really my goal to show that this transfer of technology should not be unidirectional, it should be really bidirectional. And there are a lot of lessons that we can learn from other places of how to actually treat these tumors and so on. So I'm really looking forward to this webinar, and thank you all to all the speakers for giving us their valuable time on the weekend. And thank you all to all the people that are listening.
Thank you, Said. I just would like to say a couple words and congratulate you for these amazing initiative. I think this type of initiative is what we need more, not just talks about diseases and things like that we got a little tired doing COVID and all those webinars. I think this is very important to help the world to develop and to overcome all the difficulties that we see, particularly in countries that are still developing. So I think this is it's a great initiative. Hopefully this will be recorded so many more people can watch it later on, and appreciate it.
Perfect. Well, again, thanks to everybody. So now to what you actually came to listen to, our first speaker, Dr. Claire KAREKEZI. So she has an amazing story that I've just had the pleasure of reading about, and it's great to meet her for the first time today. But she's a senior consultant neurosurgeon at the Rwanda Military Hospital and a senior lecturer of surgery at the University of Rwanda. She got her MD from the University of Rwanda and then completed her neurosurgery residency in Morocco in 2016, before then doing fellowships with a special interest in neuro-oncology and skull-based surgery, first at the Brigham and Women's Hospital in Boston in the United States, and then at the University of Toronto in Canada. She then returned to Rwanda in 2018 as the first woman neurosurgeon in the country and has won numerous awards for her leadership. So today we're really excited to learn from her regarding building skull-based surgery practice and training in sub-Saharan Africa. Dr. KAREKEZI, take it away.
Thank you so much. It's a pleasure being here. Pleasure sharing my experience, my practice, and how we're building skull-based surgery in Africa in general, and especially in Rwanda. So without further ado, I'm going to share my screen. You just let me know if you're able to see it.
Yes, looks perfect.
Okay. Okay, great. So I didn't choose to talk about skull-based building in my own country, but I thought it would be much more broad, talking about sub-Saharan Africa in general. I have no particular disclosures except that I'm a coast co-director and in the 360 degree skull-based course that we just initiated at the IRCAD Africa in Kigali, Rwanda. And we just had our first course that I will be talking about. So we know that neurosurgery comes as one of the youngest surgical discipline, and it had many years of ineffective neurosurgery with several complications until Kashi, when he came and he was able to do some surgeries with acceptable postoperative results. And then over the last years, we've seen neurosurgery evolving. So I think we had an era of improving between 90 and 2000, where we saw an incredible increase of neurosurgical techniques, treatment, new areas in the fields. And then, as you just said, in 2015, with the Lancet publication on global surgery, surgery became a concern in general. And then I think it was around 2017 that people really started talking about neurosurgery in LMICs and other developing countries, because not much was known. And global neurosurgery came as the clinical and public health practice of neurosurgery with the primary purpose of ensuring timely, safe, affordable of neurosurgical care to everyone. And then I think over that decade, around 2000, 2020, has been a lot of development in neurosurgery, especially in most LMICs countries. We saw an increase of training programs, an increase of neurosurgical workforce. And then 2019, I think, was an era of diversity. 2020 became an era of decolonizing global health, because even if those help were coming, they were coming in an adequate way. And then I think in 2022, 2023, we're talking about era of decolonizing global neurosurgery. So what about those programs that came to help? Were they sustainable? Did they really help the neurosurgeons that they came to help? That was really the real purpose. And African neurosurgery, without surprise, was almost left behind. Many causes were there, lack of financial resources, paucity of neurosurgeons, inadequate healthcare plannings, inadequate political, economic, and social environment, political instabilities and wars in most countries. And really, not a lot was known until this master paper that came in 1998 from Absalam El-Kamishi from Morocco. So you can see that of the 565 counted neurosurgeons in Africa, that was 1998, only 79, which made like 14%, were practicing in sub-Saharan Africa, which was a rate of almost 1 neurosurgeon per 7 million. So this limitation of workforce was one of the major barriers to neurosurgical care in sub-Saharan Africa. And in most countries, neurosurgery was not regarded as a priority. It was considered as a luxury care. Most people thought it was expensive, individually focused, and what was priority at that time was primary health care, malaria, maternal death, in those countries well developed. This is the master paper that I was talking about. you can see that, with 5 billion people lacking surgery, and the global neurosurgery paper showing that most sub-Saharan Africa really lacked neurosurgeons, and it was about to do something. So papers kept coming, talking about education, state of neurosurgery in Africa. Lastly, I think it was 2020, we're counting around 1,500, but you can again see that even if we came in sub-Saharan Africa, we came from 79 to 512 that time, we're still lagging behind. And then I think of the latest numbers, maybe Africa is counting more than 2,000 neurosurgeons. And this is a very recent paper published in 2024, showing that still of the 72,967 worldwide neurosurgeons, Africa was having the lowest density again, and most infrastructures were not still well developed. So Rwanda is any sub-Saharan Africa country. Not much was known since 2007. 2007, the country had a CT scan, one CT scan, and I was a medical student, you can imagine. And 2007, we had one first neurosurgeon who trained in China. Our first MRI in 2010. By 2011, we had only 2 neurosurgeons in our local training program. And in 2011, I had no other choice except finding a training abroad. So I left for training, and my colleagues started a training with 3 trainees in 2012. And I came back, as you said, in 2018. And so far, we're counting 8 neurosurgeons for 14 million people still far, but we made some progress. We count 15 residents. We have 2 programs, the University of Rwanda and the COSEXA, which is a regional program. And we count more than 10 CT scanners. Rwanda is a pretty small country, so it's possible to have a CAT scan in a short time. And we have about 6 MRIs. So what about neurosurgical education? So neurosurgical education, this is one of the papers I think we wrote in 2021 with other young African neurosurgeons. We found that there were about 76 training programs, and top programs, again, were still located in Northern Africa. And there was no standardized training. Most of the training were about 5 years in medium, but going from 4 to 7 years. We again looked at the curriculum. We found that there was no standardized curriculum. Again, programs going from 4 years to 8 years. And in Rwanda, we made similar progress, increasing trainees and producing more neurosurgeons. So this is how any neurosurgeon in sub-Saharan Africa, I think, this is not me, just me, but most of us started like this. You go back, they give you a job, and when you start, you have something like this. You have just one set. If you're lucky, you have I was like, I figured out that they have a Mayfield. They didn't know how to use it. So I just got it, and I was able to start my practice. So when you start your practice as a young neurosurgeon, you can imagine the practice doesn't come easy. It comes with more challenges, and you're asking yourself, should I do less? Should I maybe prioritize trauma, as you're saying, but how about like those, complex spine cases, complex vascular cases, complex tumors? Who is going to do that? How to build those competent neurosurgeons able to tackle those challenges, and how to keep growing, and how to keep making African neurosurgeons growing. So, some of my first cases, I was just doing everything with very minimal resources. You can see that I started operating. I will show a couple of cases I started doing, including my first skull-based cases, with just a headlight, my loops, and Hudson brace, and a couple of jigsaw saws. Tumors, come very small. And I was relying on donations in the beginning, and I was still pushing the administration to invest in neurosurgery and in the equipment. So you can see that I got some donations, but again, some of the first cases did not come very easy. Everything came huge, as you say. Each tumor was huge. Each trauma was crazy. And, you know, it's not just like what you just learn in school. You have to tackle all these challenges. So these are some of my first skull-based cases. I think this was a 60-year-old female who came in with this big sphenoid wing meningioma. I think it was more medial, but pushing the MCN carotid on the side. So you have to plan, because I had very limited resources, but you know, I had to help her. This is a tumor pretty much removed easily. Was surprised, and patient did well. Some of the next case, this case was a sphenoorbital meningioma with this destroyed orbital and temporal bone that I removed and did the reconstruction. Small lateral sphenoid wing meningioma again, done beautifully. And then I started seeing those OGMs. You know, I would say this is very small compared to what we see generally. Great removal, patient did well. This was a tuberculum cell meningioma, and this was more of an OGM frontal meningioma removed. This was an NF2 case that was complicated because this patient presented with a huge meningioma, bilateral vestibular schwannomas, and you can see a C4, C3, I think, schwannoma that I first removed the meningioma, and then the schwannoma in the cervical spine, and I was still planning to remove the vestibular schwannomas. So our modern neurosurgery equipment, you can see they remain very high and very expensive in LMSs. If you look at everything you need in the theater, you know, everything maybe altogether will cost more than $1 million US. And in most countries, this is just too much, and it's very hard to convince the administration to invest it. But you have to keep pushing. This is us last year, so we kept pushing. It took about 4 years, but we finally got our first microscope, and we got a tower. We got all the set, Cababianca set, and ATV set. Just, you know, because, you know, I would sit on the table and I would tell them, you know, these patients are there and they need to be done, and, you know, you have to invest. And we're still building, I think, a low-cost navigation system with Alex Golby, who has been visiting more often. She has come to Rwanda 3 times now. So you can see that this allows you to tackle more bigger cases with more visibility. So you can see how OGMs come. So I don't even know if this is an OGM or tuberculum cell or what. It's a combination of everything. It comes from front, goes behind, and it's very hard to do this with just your eyes, and you need a very good visibility. So this is a patient that I did with a brand new microscope, and she did pretty well. So we're able to decompress her optic apparatus. So this was another complex patient who presented with this third ventricle tumor that was thought to be a craniopharyngioma, but I think the tumor was more of a optic pathway glioma, because it was more of a solid tumor. You can see the exposure, the visibility, pretty much good resection, but this patient had a DI, and he passed away from hyponatremia. So even if you do a good job, even postoperative period can be challenging in our settings, because you have to take everyone with you. You need endocrinologists, you need everyone who understands, and you need a good follow-up for patients. So these are a few of my craniopharyngiomas. I just decided so they come also huge craniopharyngiomas. And I just, you know, most of the patients are poor. They will not afford hormonal replacement. So why not doing less? So I'll put just a catheter, let the cyst come down, and most patients did very well. So this is another case. So when you look at the cases I receive every day when I do my clinics, so it's just every skull-based pathology that you can imagine, from pituitary adenoma, KAREKEZI, I think this was one of my latest case. It's tuberculum cell meningioma that goes down in the prepontine. I also had this foramen magnum meningioma. So every case is a bit challenging and requires a bit of training in skull-based surgery. So in 2021, again, we did a survey. We surveyed about 112 young residents and young neurosurgeons from 20 countries in sub-Saharan Africa. And we asked them, what do you need? What do you think should be done to help you growing? Because we have now so many programs, and everyone is able to do trauma and the basic neurosurgeries. But most of them, what they responded, they said they needed subspecialty training. They needed to train in those complex cases, either skull-based, spine cases, and they said that they needed cadaveric causes. And when you look at cadaveric causes, very scarce on the continent. And I think even in developing countries, in HICs, these causes are maybe started not long ago. But this remain maybe the most adequate simulation you can have before tackling a very complex case. So in most LMICs, including Africa, those causes are almost non-existent. And you can see that most skull-based surgeons, even if they will call them skull-based surgeons, they will still tackle all cases via conventional pterional, suboccipital retrosigmoid, subtemporal approaches. But all those other crazy approaches, not really very mastered or really very known, because you need to be in a skull-based laboratory. You need to practice. You need to demystify those approaches so you can be able to do them. So when you go in the skull-based laboratory anatomy, you learn the bone structures, major arteries, venous structures, perforators, cranial nerve relationship, and you learn how to handle the drills, the bars, and everything, all those small details, but very important details in skull-based surgery. So unfortunately, those courses need investment from government, from health ministries, and from partners, because most of the equipment that are used in the courses are very expensive also. So I think you heard, I will talk about ICAD Africa, but this is an example. I think this is a skill laboratory that was set in West Africa by my friend Landry Conan. So they started with very few tables, but they're able to do courses every 3 months, and they do basic suture technique course, how to use a high-speed drill, for instance, skull-based. They did neuroanatomy and endoscopic approaches, and they did a couple of spine courses as well. So this is one of the great examples, and I think they are among the few people that have a skill lab dedicated to skull-based surgery. And we tried to do a similar course. I think that was 2021. So that time, ICAD infrastructure was not built. You can see this Professor Fresh. So we were able to get 4 cadavers, and we had few trainees. And our main sponsor was TOLS, so we did mainly endoscopic approaches, but we could not do, we're not prepared to do open approaches. But from there, we knew that the ICAD Africa was being built, and that eventually we can set an adequate skull-based course like in any other country. So I will talk about the ICAD Africa experience. You can, I think some of you know that ICAD started in Strasbourg, France, and started expanding in different countries. So The one institute that is in Africa is located in Kigali, Rwanda. So to build this institute, my government invested more than 20,000 US dollar just for the infrastructure. The infrastructure is magnificent, very nice infrastructure, nice auditorium and nice lab with 15 tables plus one master table. So with a capacity of training 30 trainees. So we started with different specialties, including ENT and neurosurgery, joining together to do the skull-based course. So in the beginning, of course, because the institute was launched last October, we could not be among the first one to conduct a course because you need a couple of things that I'm going to show you to be able to conduct a real skull-based course. But some of the discipline were running and they were using pigs as anatomic species, and they mostly do laparoscopy, so stalls was on board, and they did not need many equipment like neurosurgery. So when it comes to neurosurgery, we started advertising for the May course, I think last year. And even if we had a very well equipped lab, so you can see that the towers and are already mounted. So we needed to bring all this stuff on board. So where to get microscopes, where to get head holders, where to get so to get the anatomical specimen. We already were in contact with our anatomy department at the University of Rwanda, and there is a law in Rwanda that allows to give non-claimed bodies for education. Otherwise, we will not be able to get the head specimen. But our anatomy department never injected a head. So they said we're going to fix the head, but we don't know how to do the injection because, you know, someone had to come and teach them how to do the injection. Anyways, so we had a couple of meetings since last year, strategizing, bringing everyone on board. So we could not get Integra. This is a very funny picture. I like to show it. I was in Italy for another skull-based course. So I asked them, where do you put the head? They told me, you just get a small basin like this. So I went in a supermarket and I saw these small basins, and I was asking this guy that works at the institute, can you put it on your head? Because I was at work, I could not go myself. If it fits your head, so then the head is going to fit. And so eventually, the course was set. We had to bring in our partners and sponsors. These, I think, were equipment. This is just Sunday before the course starts on Monday, and everything had to be shipped in, customs and everything. So Sunday evening, finally we got everything from Medtronic, everything from Zeiss, and we're able to set our lab and to mount everything together. So these were our main sponsors. Source came in, Medtronic came in, this is an anatomy lab, Bissinger's Germany company that manufactures some microsurgical instruments. And of course, they shipped in 11 small microscopes. Otherwise, we could not do the transcranial approaches. So we had a very good number of trainees that came from different countries. You know, it was a risk because we weren't sure we're going to have all the equipment on time, but we took the risk. So we had everything on time. And this is us, you know, the day of the course. You can see that the small basin, so it will move if you're drilling. So we had to find a way of fixing it. So this is one of the tech lab nurse. He was able to fix it on the table, and it was well fixed. So the course was very designed. Like I've attended the ICAD France several skull-based courses, and I would say that there was no real difference except not having Professor Prevedero, for instance, in Rwanda, because we weren't sure of the first course. So we only had Professor Flourish and one of his residents. but I invited a couple of colleagues from Senegal, Nigeria, Kenya, who came and gave some lectures. So mornings we did anatomical teaching and all the approaches they were going to do. So we decided we were going to have the exact same course as the one in France. So it was a complete 360-degree, and afternoon everyone enjoyed the lab. You can see we're so surprised. Though the specimen were not injected, the fixation was pretty great. So the skin was smooth, the anatomy layers were conserved, and we had a very successful course. These are some of the residents who were able to do many dissections, even as, you know, as course guiders, we were also, you know, improving and learning from each presenter. So my two residents, they were able to do an F2OZ, you can see, and I was very happy. And, you know, this is me and colleague from Senegal. She does most endoscopic and nasal surgeries, and she was demonstrating the endonasal approach. So this was the panel of faculty from France, Nigeria, Rwanda, Senegal, and everyone came in, and all the trainees, and they were very satisfied. So, and these are some of the sponsors. I think these guys are from Medtronic, DICE, and our faculty members. I think from there, of course, you have to go several times, but each time you go, you become very familiar, and you feel more confident in doing adequately some of these approaches. And I will tell you that just after the course, I started seeing crazy stuff. Like this case, you know, when I was asking Professor Fresh, he said, you need to do an F2OZ. I said, oh, can I really do an F2OZ on my own? I said, okay, let me tackle it. I just finished a course, and I was able to do a very nice F2OZ in this guy. I will pass, so you can see retrograde dissection of the temporalis muscle, exposure of the lateral rim of the orbit and zygoma, IOF identification, all the steps, just like I learned in the skull base. Otherwise, if I didn't go in the lab, I will not be able to do this. So McCarthy keyhole adequately, and you know, this nice piece F2OZ came in one piece. I had a little bit of orbital fat, sorry. I could not preserve the periorbita, and I was going down, taking down the lesser wing, and I think I completed with an anterior clinoidectomy that you can see that I'm doing here. So when I opened, so the idea is to work in this corridor without having the bone obstructing you. You can see this was very nice meningioma. When I opened the corridor, the meningioma was just, you know, beautifully exposing itself. And I felt like, you know, I was in France doing, or in the US doing this complex skull base on my own, and doing a very nice approach. At the end, I think you will see I expose the carotid, ACA, middle cerebral artery, and remove everything so beautifully, and patient did well. So this is the patient, nice cosmesis, doing well, and I was proud of myself. So I said, if I didn't go to the skilled lab, I would not be able to tackle such a case. Just after this guy, I get this, you know, foramen magnum meningioma. I said, oh, this one I'm going to kill her because I cannot. I can't. I said, okay, this woman, she's becoming quadriparetic. I need to do something. So I said, I'm going to do a far-lateral approach. So if I didn't go to the lab, I wasn't going to be able to do a far-lateral approach. So I did the far-lateral approach. I could not monitor any cranial nerve because I don't have any monitoring. I said, I'm going to use my anatomy. I'm going to check every fibers and make sure I don't take anything. Sorry, I'm about to finish. So, beautiful exposure. and the meningioma was just there, and I started bulking it. And this is, I think, at the end where you see the vertebral artery, V4 cavity, and everything well, nicely done. And she did very well. I was surprised she did well. I think I took a little branch of 11. She had a little bit of weakness in the left shoulder, but I'm happy I didn't kill her. Anyways, if I didn't go to the lab, I would certainly kill her. So this is what comes to you when you're in Africa. They will not come small. They come like this. So you have to be able to tackle them. This was a case I just did last week. It was going everywhere. Tuberculum, down, diaphragm, prepontine. And I did my best, but this patient is already blind. So, you know, a lot has been done. A lot has been done. We're still developing, but I think we can do better. We have the skills. We can have the skills. We can train our residents. We can train our young neurosurgeons, and they can become as efficient as any neurosurgeon anywhere. But we need to bring on table different partners. We need to bring on table government, health ministries, so they can invest in technology, because neurosurgery is a field that relies a lot on technology. So I cannot finish without thanking one of my great mentors, Prof. Gentili. When I was about to start my my practice, he told me that he had, he was sure I was going to do just well, and he just had trust in me, and that helped me a lot. And of course, eternal mentor Flourish, who has been behind all this skull-based development. And this is my beautiful country, and you can come anytime. Thank you so much.
Very good, Claire. I feel obligated to say the first words here because you mentioned me, and I just want to, in public, tell you that congratulations, first of all, beautiful work. And I just want to publicly state that I'll be happy to help you with the next course.
Absolutely.
Yeah, keep it. I wasn't aware of your course,
no, we didn't tell anyone because we weren't sure everything was going to come together.
But
so,
be happy to help in the next one. I guess we can communicate in parallel later, and then I'll be happy to help with whatever I can to establish a nice continuation of our great work.
Absolutely. Thank you so much. Sorry, I took so much time, but I felt like I had to tell all these stories behind.
Oh, that was beautiful, Dr. KAREKEZI. Really appreciate the whirlwind tour of the entire sub-Saharan Africa experience, and especially the Rwandan experience. It is beautiful. So just being mindful of time, we can segue to our next speaker and then save some more questions towards